Welcome back to the deep dive. Today, we're setting our sights on a fascinating and incredibly critical part of your digestive system, the gallbladder and its complex network of bile ducts.
Yeah, it's often the unsung hero, isn't it?
Or maybe the silent partner, right? Until it decides to demand your attention. And when it does, well, things can get complicated fast.
That's absolutely right. And for this deep dive, you brought us some serious source material. I mean, straight from a comprehensive surgical textbook. So our mission here isn't just a casual overview.
Oh, definitely not.
We're going to navigate this system really through the lens of surgical practice, understanding the precise anatomy, the way it's supposed to work, and then digging into what happens when things go wrong.
Everything from gallstones.
The incredibly common gallstones, yeah, right up to the rarer congenital issues and even, unfortunately, cancers. We're aiming to give you an understanding that gets close to the kind of clarity professionals need in this field.
Think of this as understanding the blueprint, maybe, and the potential failure points of a vital piece of internal machinery. We'll start with the foundations, how it's built, how it functions normally.
The nuts and bolts first.
Exactly. Then we'll explore the detective work involved, how doctors use imaging to see inside. After that, we'll dive into the various problems, how they're diagnosed, and crucially, how they're managed, including the surprisingly intricate world of biliary surgery.
It's a lot to cover.
It is. It's all tailored just for you, the listener, based on the detailed material in our hands. So let's get started and truly unpack this.
All right, let's do it.
So let's begin with the star of the show, the gallbladder itself. Imagine a small pear, typically somewhere between, say, 7.5 and 12 centimeters long.
Not huge, but important.
Definitely not huge, but it has a job to do, capable of holding about 25 to 30 milliliters of liquid gold bile. Our source describes its shape, breaking it down into a few key areas: the rounded bottom, the fundus, the main body, the neck, which tapers down, and finally, the infundibulum, also sometimes called Hartmann's pouch, right before it connects to the cystic duct.
Got it.
You'll find this nestled neatly on the underside of the liver, usually in that groove between the right and left lobes. What's interesting is its position isn't always fixed. It can be tucked right into the liver or sometimes hang a bit more freely on a stalk.
That variability is key.
And structurally, the muscle in its wall has this distinctive crisscross pattern, particularly noticeable in the neck, which is thought to help it squeeze effectively. Inside, the lining isn't smooth. It has these little folds or indentations known as the crypts of Luschka.
Named after Hubert Luschka, the anatomist. And right away, these anatomical details start mattering when you consider surgery. Take the cystic duct, that narrow tube connecting the gallbladder to the main bile highway.
Right.
Our source notes it's about 3 centimeters long, but that length can be surprisingly variable, which is a critical point for surgeons. Its inner channel is tiny, maybe just 1 to 3 millimeters wide. Very small. Inside, it has these spiral folds, often called the valves of Heister, after Lorenz Heister. They aren't true valves that open and close, though.
Okay, so not like a one-way door.
No, exactly.
Yeah.
But they can make it a bit tricky to pass a catheter through, which is sometimes needed during imaging or surgery. Around the duct wall is a band of muscle, the sphincter of Litkens, described by Ulrich Litkens, helping regulate flow.
Okay.
Now, where the cystic duct joins, the common hepatic duct is usually straightforward above the duodenum in about 80% of people. But this is where variability really gets important.
Ah, the exceptions.
Always exceptions in anatomy. It can join much lower, run right alongside the common hepatic duct for a distance before joining, or even join higher up, right into the liver ducts themselves. Recognizing these detours and alternative routes is paramount during surgery to avoid, well, disastrous mistakes.
Absolute crucial. Following the path of bile further, we reach the common hepatic duct. This is formed by the merging of the smaller ducts draining bile from the right and left sides of the liver. It's usually quite short, less than 2.5 centimeters.
Pretty short, yeah.
Then the cystic duct joins in, creating the common bile duct, or CBD. The CBD is longer, roughly 7.5 centimeters in total, and it has quite the journey as it travels down towards the small intestine.
It really does wind its way down.
It does. Our source breaks it into 4 parts. The supraduodenal part running within the free edge of the lesser omentum.
Okay.
The retroduodenal part tucked behind the first part of the duodenum. The infraduodenal part, which lies in a groove on the back of the pancreas.
Oh, on the pancreas there.
And finally, the intraduodenal part as it passes through the wall of the second part of the duodenum. This final segment is surrounded by the sphincter of Oddi, named after Rigro Oddi, a muscular valve controlling bile and pancreatic juice flow into the intestine.
The gatekeeper.
The gatekeeper, exactly. It opens at the ampulla of Vater, named for Abraham Vater, a little nipple-like structure on the duodenal wall. It's quite the anatomical obstacle course just to get bile to its destination.
It really is. And supplying all these critical structures is a network of blood vessels. For the gallbladder itself, the main supply is the cystic artery. Typically, this branches off the right hepatic artery and runs behind the common hepatic duct.
Okay, behind is typical.
Behind is typical, but again, variations. In about 15% of cases, the right hepatic or cystic artery can cross in front of the main ducts, placing them at higher risk during dissection.
That's a significant percentage.
It is. And there can also be extra or accessory arteries supplying the gallbladder from places like the gastroduodenal artery. The bile ducts themselves get blood from smaller vessels, the choledochal arteries forming a delicate network, the epicholedochal plexus, along the duct walls.
Like a mesh.
Exactly, like a mesh. These connections ultimately link back to the hepatic arteries, and arteries supplying the pancreas and duodenum. This delicate blood supply explains why damage during surgery can sometimes lead to strictures, scarring, and narrowing, even without a direct cut. Disrupting the blood flow can starve the duct wall.
Wow. So, given all this variability in delicate anatomy, surgeons rely on key landmarks to stay oriented, especially during laparoscopic surgery where the view is magnified and, well, limited.
Absolutely essential.
One of the most famous is Callot's triangle, originally defined by Jean-Francois Callot using the cystic duct, common hepatic duct, and the cystic artery's superior border. However, modern surgeons often use a slightly redefined area, sometimes called the hepatocystic triangle.
Right, a more practical definition sometimes.
This is bounded by the liver's underside above, the cystic duct and gallbladder to the side, and the common hepatic duct towards the middle. This triangle is the typical hunting ground for finding the cystic artery and also the cystic lymph node.
The sentinel node of Lund.
Often called the sentinel node of Lund after Fred Bates Lund, though Paolo Mascagni also described it. Finding this node can sometimes help locate the artery.
Another crucial concept, particularly for the critical view of safety in laparoscopy, is the cystic plate. This is a tough fibrous layer in the liver bed where the gallbladder sits, connected to the liver capsule, specifically over segments IV and V of the liver.
Okay.
And then there's Rouvier's sulcus, named after M. Henri Rouvier, a groove on the liver's underside near the porta hepatis. Identifying this sulcus and mentally mapping the R4U line that's from the roof of Rouvier's sulcus across liver segment 4 to the umbilical fissure is a vital trick.
Why is that line so important?
Because the cystic duct and artery consistently lie in front of and above this line, while the common bile duct, the CBD, is below it. So keeping your dissection forward and upward or ventral to this line is a fundamental safety measure to avoid accidentally cutting the CBD during a cholecystectomy.
Stay above the line.
Stay ventral to the line. Our source also knows a variation where the right hepatic artery does a funny twist near the gallbladder, sometimes nicknamed the caterpillar turn, or Moynihan's hump, after Lord Moynihan. That can be a dangerous neighbor in this area.
Good to know. We should quickly mention venous and lymphatic drainage, too. Veins mostly drain back towards the portal vein system, connecting via things like the epicholedochal venous plexus.
Right.
Lymphatics from the gallbladder drain first to that cystic node of Lund near the duct, then onwards to nodes at the liver hilum and eventually the coeliac nodes. That connection between the gallbladder and liver lymphatics is significant because it's a common pathway for gallbladder cancer to spread directly into the liver.
Yeah, that direct spread is a major issue in cancer. Now let's talk function, the physiology. Your liver is constantly producing bile, maybe about 40 milliliters every hour.
Constantly churning it out.
Pretty much. Bile is mostly water, like 97%, but that other 3% is packed with crucial stuff. Bile salts, which are essential for fat digestion.
The emulsifiers.
Exactly. Plus phospholipids, cholesterol, and bilirubin. That's the pigment that gives bile and eventually stew their color. The body is incredibly efficient, though. A process called enterohepatic circulation means about 95% of those valuable bile salts are reabsorbed in your lower small intestine, the terminal ileum, and recycled back to the liver.
Very efficient recycling system. And the gallbladder's role in all this?
Well, it's primarily a storage and concentration unit. When you're not eating, the sphincter of Oddi down at the duodenum is usually closed tight.
Okay.
This backs up bile coming from the liver, diverting it into the gallbladder. It acts like a holding tank, a reservoir.
Got it.
Then, after you eat, especially fatty foods, hormones like cholecystectomy or CCK signal the gallbladder to contract, The sphincter of Oddi relaxes, and a concentrated squirt of bile is released into the duodenum to help break down those fats.
So it concentrates it too.
Oh yeah, big time. It actively concentrates bile by absorbing water, sodium chloride, and bicarbonate, making it maybe 5 to 10 times stronger than the bile directly from the liver. And one more thing, it secretes mucus, about 20 milliliters a day. This becomes important if the cystic duct gets blocked. The gallbladder keeps making mucus, can't get rid of it, and fills up, leading to what's called a mucocele.
A gallbladder full of mucus.
Pretty much. Understanding that function is key to seeing why problems develop, particularly with stones. But before we dive into pathology, how do doctors actually peer inside the system? Imaging is absolutely crucial.
Okay, let's look at the toolkit for visualizing the gallbladder and bile ducts. Starting with the simplest, plain radiographs, like a standard X-ray. Honestly, their use here is pretty limited these days.
Not the first choice, usually.
Right. You might only see gallstones if they happen to be radio-opaque, meaning they contain enough calcium to show up, and that's only about 10% of them. The source mentions figure 71.4 showing this. You might see calcification of the gallbladder wall, which is known as a porcelain gallbladder. Figure 71.5 shows an example. That can be significant because of a slightly increased cancer risk.
Right, that porcelain look.
Sometimes you might see gas in the gallbladder wall, which indicates a nasty infection called emphysematous cholecystitis. There's a figure 71.6 for that. Or maybe gas in the biliary tree itself, which could suggest a prior procedure, or more concerningly, a connection to the bowel.
Like a fistula.
Exactly. If you're really lucky, you might spot a stone with central gas, sometimes called the Mercedes-Benz sign or Siegel sign. But for the most part, plain X-rays aren't the primary tool anymore. Things like oral cholecystography are pretty much historical now.
Yeah, replaced by better tech. The initial workhorse, the first line of imaging, is almost always transabdominal ultrasonography, or USG. Figure 71.7 shows a typical view.
Ultrasound.
Ultrasound. It's widely available. It's inexpensive, non-invasive, quick. Now, it does depend on the skill of the person doing it, the operator. And it can be tricky with obesity or a lot of bowel gas getting in the way. But it's generally excellent for seeing the gallbladder itself, its size. Whether stones or polyps are present, the thickness of the wall, more than 3 millimeters, is a red flag.
3 millimeters.
Fluid around it suggesting inflammation, and importantly, eliciting the ultrasonographic Murphy sign. That's tenderness when the probe presses directly on the gallbladder, named after John Benjamin Murphy.
The same Murphy as a clinical sign.
The very same. It's also invaluable in someone with jaundice. It can quickly show if the bile ducts inside or outside the liver are dilated, suggesting a blockage, and maybe hint at the level or cause, whether it's stones, strictures, or even a mass. Figure 71.20 shows duct dilation from obstruction.
Okay. For a more detailed look, particularly maybe at the lower end of the common bile duct where it runs behind the pancreas, there's endoscopic ultrasonography, or EUS.
Yeah.
Figure 71.8 gives an idea.
Right, the scope of the ultrasound tip.
Exactly. This uses an endoscope with an ultrasound probe at the tip, giving you an up-close view from inside the stomach or duodenum. It's very accurate for finding small stones in the CBD that might be missed on regular ultrasound. And it's really good for assessing and staging tumors around the pancreas and the ampulla of Vetterer. Plus, you can often take biopsies during the same procedure.
Very useful for those tricky spots. Then we have functional imaging, like cholecystectomy, commonly called a HID scan. Figure 71.9 illustrates this.
HID scan, okay. How does that work?
It uses a radioactive tracer, usually a 99 millocc labeled IDA derivative, that your liver treats like bilirubin. It gets excreted into the bile. So the scan lets doctors watch the flow of bile. Normally, the tracer should fill the biliary tree in the gallbladder pretty quickly, within about 30 minutes, certainly within an hour. And you should see it moving into the bowel within an hour, too.
So what's the key finding?
The crucial finding is if the gallbladder doesn't show up on the scan. Non-visualization strongly suggests acute cholecystitis because the cystic duct is blocked, usually by a stone, preventing the tracer from entering.
Makes sense.
It can also show reduced or delayed filling in chronic cholecystitis, where the gallbladder might be scarred down. Its use for gallbladder dyskinesia, looking at how well the gallbladder squeezes based on an ejection fraction, is mentioned as somewhat controversial in the source material. But it's definitely useful for finding bile leaks, confirming obstruction, or checking if surgical connections like a bilioenteric anastomosis are open.
Okay. Moving to cross-sectional scans, computed tomography, or CT. Figure 71.10 includes a C2 example. You mentioned it's less affected by body habitus than ultrasound.
Right, and it's not operator dependent in the same way.
So what does CT show well here? It's less good for spotting most gallstones, right? Only about 75%.
That's right. It's not the screening tool for uncomplicated stones. But in acute cholecystitis, it can clearly show a swollen, distended gallbladder, thickening of the wall, maybe some edema or fluid, and inflammation in the surrounding fat, called fat stranding. Where CT really shines, though, is in assessing the surrounding organs, the liver and pancreas. And critically, it's essential for staging cancers of the gallbladder, bile ducts, pancreas, or liver. It shows how far a tumor extends, if it involves major blood vessels, and if it has spread to lymph nodes or other organs like the lungs. So while not the first choice for simple stones, it's invaluable for evaluating complex problems or suspected malignancy.
Got it. Essential for the bigger picture, especially cancer.
Precisely. And then there's magnetic resonance cholangiopancreatography, MRCP. Figures 71.11 and 71.1 show MRCP images. This is a non-invasive marvel, really.
How so?
It uses MRI technology to get stunning images of the entire biliary tree and the pancreatic duct. It looks almost like a contrast study, like an ERCP or PTC, but without injecting contrast directly into the ducts themselves, so you avoid the potential complications of those procedures.
So safer, but good pictures.
Exactly. It's fantastic for clearly showing ductal abnormalities, blockages, strictures, stones, or tumors within the ducts. It provides a detailed map of the ductal anatomy, including the precise level and nature of any injury, if that's the concern. You can even combine it with MR angiography to look for associated vascular problems or injuries.
Wow, that sounds incredibly useful. Now, what about endoscopic retrograde cholangiopancreatography, ERCP? You mentioned it's less diagnostic now. Figures 71.10, 71.11, 71.15 show ERCP in action.
Yep, its role has shifted. As we said, MRCP and USG often handle the initial diagnosis. Today, ERCP is primarily therapeutic.
So it's more about fixing things.
Exactly. It involves passing a special side-viewing endoscope down into the duodenum, finding the ampulla of Vater, and carefully slipping a tiny catheter into the bile duct opening to inject contrast. This still provides incredibly detailed images of the duct anatomy and any blockages. But its real power is that at the same time, you can pass instruments through the scope to perform interventions, snaring out stones with the basket, dilating strictures, placing plastic or metal stents across strictures or leaks, or taking brushings or biopsies for analysis.
So diagnosis and treatment in one go.
Potentially, yes. And a newer adjunct mentioned is cholangioscopy. This involves passing an even tinier flexible scope through the main ERCP scope.
A scope within a scope.
Right. It allows direct visual inspection of the inside of the bile ducts. This is indicated for things like indeterminate strictures, suspicious nodules, or even for using lasers to break up large stones under direct vision lithotripsy.
That's quite advanced. What if you can't get access from below with ERCP?
That's where percutaneous transhepatic cholangiography, or PTC, comes in. Figure 71.16 shows this. This is usually reserved for situations where ERCP isn't possible, typically if there's a blockage high up in the biliary tree near the liver that prevents the ERCP scope from reaching it.
And this is done through the skin.
Yes, it's more invasive. A needle, like the fine Shiba needle or the Okuda needle after Kunio Okuda, is guided under fluoroscopy or ultrasound control through the skin and liver tissue into one of the bile ducts inside the liver.
Okay.
Contrast is injected to visualize the ducts, usually upstream of the blockage. Its main use today is therapeutic to gain access for placing drainage catheters to relieve pressure and jaundice caused by the obstruction. The drain can be external, collecting bile in a bag, or routed internally past the blockage into the duodenum.
Can it still be diagnostic?
Yes, it is diagnostic too, showing the location and nature of strictures or obstructions. And importantly, leaving a drainage catheter in place for several weeks allows a mature tract to form through the liver. This tract can then be used by an interventional radiologist to directly access the bile ducts from the outside for procedures like retrieving stones, a technique described by H.W. Ken, often called the Burhan technique.
Interesting. So quite a range of imaging options.
Definitely. The source provides a handy summary box, 71.1, recapping the strengths. Plain radiograph for calcification error, USG as the essential first step for stones dilatation, MRCP for non-invasive anatomy and stones, CT for anatomy, complex issues and cancer staging, HIDA for function and leaks, ERCP mainly therapeutic but also diagnostic, PTC for drainage from above and diagnosis when ERCP fails, and EUS for detailed views near the pancreas.
And you mentioned imaging can even be used during surgery.
Yes, intraoperative imaging. Preoperative cholangiography is one example, shown in figures 71.17, 71.18, 71.19. During a cholecystectomy, either open or laparoscopic, a small catheter is placed into the cystic duct stump and contrast is injected.
What's the main goal there?
Primarily to check for any unsuspected stones lurking in the common bile duct, although it also confirms the anatomy. Careful technique is needed, tilting the patient on the table and making sure no air bubbles are injected, as they can look like stones. Then there's operative biliary endoscopy, or cholecystectomy. This involves passing a small flexible endoscope directly into the bile ducts, usually through the cystic duct, or a small incision in the common bile duct, a cholecystectomy, during surgery. It allows the surgeon to visually confirm that all stones have been removed.
Seeing is believing.
Pretty much.
Pretty much.
If a stone is left or suspected, sometimes a T-shaped drain, a T-tube, might be inserted into the common bile duct, creating that track for later radiological stone removal using the Berhen technique we mentioned. Finally, laparoscopic USG uses a special ultrasound probe during laparoscopic surgery for close-up imaging, which can be particularly useful for tumor staging by assessing how a mass relates to nearby blood vessels.
Okay, a really comprehensive imaging toolkit. Let's shift focus now to conditions that are present from birth congenital abnormalities. The source touches briefly on embryology.
Right, how the whole system develops from a little bud off the primitive gut, the foregut. This bud forms the main duct, the choledochus, and then a side bud develops into the gallbladder and cystic duct. There's a temporary phase where the ducts are solid before they recanalize or hollow out. And interestingly, the gallbladder starts out inside the liver parenchyma before moving to its usual spot underneath.
So what can go wrong during development?
Well, occasionally someone is born completely without a gallbladder agenesis. It's rare and important not to mistake its absence for a diseased, shrunken one. Variations in shape are much more common. The classic one is the Phrygian cap, shown in figure 71.20b.
Phrygian cap, like the hat.
Exactly like the ancient hats worn by the Phrygians. The fundus, the bottom part of the gallbladder, is folded over on itself. It's found in about 5% of people, and it's just a normal variant, completely harmless, though sometimes mistaken for deformity on imaging. A floating gallbladder, one attacked by long mesentery instead of being snug against the liver, is rare, but makes it prone to twisting on its stalk torsion, which is a surgical emergency.
Okay, what about variations in the ducts?
These are generally more surgically significant. Absence of the cystic duct is usually not congenital, but pathological, often the result of a stone passing through or inflammation eroding the duct wall directly into the common bile duct. This situation, sometimes associated with Marizzi syndrome, named after Pablo Luis Marizzi, makes surgery very tricky because the gallbladder connects almost directly to the main duct.
High risk of injury there.
Very high. Low insertion of the cystic duct, where it joins the common bile duct much lower down near the pancreas, is another important variation to recognize, figures 71.21, 71.22. If a surgeon dissects too far down thinking they're still on the cystic duct, they can easily damage the common hepatic duct or the CBD, or even strip away its delicate blood supply, leading to later strictures. And then there are accessory cholecystohepatic ducts, shown in figure 71.21. These are uncommon extra ducts running directly from the liver parenchyma into the gallbladder wall or cystic duct. If small, they might just leak a bit after gallbladder removal, but if larger, they need to be identified and carefully closed, making sure you're not accidentally ligating a major duct like the right hepatic duct.
Lots of potential pitfalls.
Absolutely. Which brings us to a much more severe congenital problem. Extrahepatic biliary atresia. Figure 71.23 gives a schematic. This condition, famously associated with the surgical pioneer Morio Kasai, affects about 1 in 12,000 newborns.
What exactly is it?
It's a devastating, progressive, inflammatory disease that essentially destroys the bile ducts outside the liver, usually starting around the time of birth. If it's not treated, bile can't get out of the liver, leading rapidly to irreversible liver damage, cirrhosis, and portal hypertension, often by age 3.
How is it classified?
The Kasai classification, also referred to as the Japanese Anglo-Saxon classification, describes types based on which ducts are affected. Type I involves only the CBD being blocked. Type 2 affects the common hepatic duct, either with patent downstream structures, II, or obliterated ones. Type 3, the most common, involves blockage right up to the small ducts at the liver hilum. Whether the gallbladder fills with bile can sometimes give a clue to the type.
How do these babies present clinically?
The hallmark is jaundice. About a third might be jaundice at birth, but virtually all will be by the end of the first week, and the jaundice deepens. Because bile isn't reaching the intestine, their stools are pale, like clay or putty colic stools.
No color.
Right. And the bilirubin backs up and gets excreted by the kidneys, so their urine is unusually dark. They can also be very itchy, pruritus, and longer term can develop finger clubbing, skin deposits called xanthomas, and problems absorbing fats and fat-soluble vitamins, leading to poor growth and bone problems like biliary rickets. Liver function tests show a pattern consistent with biliary obstruction, high bilirubin, and alkaline phosphatase, ALP.
Are there other associated problems?
Yes, in about 20% of cases, there are other non-liver congenital anomalies like heart defects, polysplenia syndrome, multiple spleens, cetus inversus, organs reversed, absent vena cava, or a preduodenal portal vein in front of the duodenum instead of behind. Sometimes suspicion arises even before birth, if fetal ultrasound shows a cystic structure near the liver hilum.
How is the diagnosis confirmed?
Fasting ultrasound is the gold standard initial test. Key findings are small, shrunken, or even absent gallbladder after fasting, and sometimes a characteristic dense echogenic area at the liver hilum called the triangular cord sign, thought to represent the fibrotic remnant of the ducts. Hepatobiliary scintigraphy, like a HIDA scan, can be helpful, showing uptake by the liver but no excretion into the bowel. MRCP is also highly sensitive and specific. Ultimately, a liver biopsy is often needed to confirm the diagnosis, showing characteristic features like inflammation, fibrosis, cholestasis, bile backup, and proliferation of tiny new ductules. Sometimes a direct cholangiogram is needed to define the exact anatomy for surgery.
What else could cause similar symptoms in a newborn?
It's crucial to differentiate biliary atresia from other causes of neonatal cholestatic jaundice. This includes things like alpha-1 antitrypsin deficiency, cholestasis from IV feeding, choledochal cysts, or inspissated bile syndrome, thick bile plugs. More common differentials include genetic conditions like Alagille syndrome, named after Daniel Alagille, which involves bile duct problems plus other features, or progressive familial intrahepatic cholestasis, PFIC, or cystic fibrosis. The most difficult distinction is often from severe neonatal hepatitis. Liver biopsy and radionuclide scans are key here.
What's the treatment for biliary atresia?
It starts immediately with aggressive nutritional support, often using special feeds with medium-chain triglycerides that are easier to absorb, and supplementing fat-soluble vitamins, A, D, E, K, especially if the infant is breastfed. But the definitive treatment is surgery. For the rare type I cases, a direct connection between the patent upper duct and the intestine, Roux-en-Y hepaticogedostomy, named after Caesar Roux, might be possible. But for the more common type 2 and 3, the standard operation is the Kasai procedure, or portoenterostomy. This involves radical excision of all the fibrotic remnants of the extrahepatic bile ducts right up to the liver capsule at the porta hepatis. Then a loop of small intestine, the Roux loop, is brought up and sewn directly to this exposed area of liver capsule, hoping to allow bile to drain from microscopic ductules directly into the gut. Does the timing of the surgery matter? Critically, the chances of success, meaning restoring bile flow, are highest if the Kasai procedure is performed before the infant is 8 weeks old. If bile flow is established and bilirubin levels normalize, the 10-year survival rate can be as high as 90%.
What are the potential complications after the Kasai procedure?
Unfortunately, complications are common even with successful drainage. Bacterial cholangitis, infection ascending up the Roux loop into the liver, occurs in about 40% of patients and can lead to progressive fibrosis. Portal hypertension develops in about half of long-term survivors, and about a third may experience bleeding from esophageal varices. If a portoenterostomy fails to restore adequate bile flow, or if liver failure develops despite initial success, then liver transplantation is the only remaining option. Results for transplantation in these children have improved dramatically, with 70–80% survival at 2 to 5 years reported.
A really challenging condition. What about congenital problems inside the liver ducts?
That brings us to congenital dilation of intrahepatic ducts, also known as Caroli's disease, after Jacques Caroli. This is a rare condition characterized by saccular or cyst-like dilations of the bile ducts within the liver. The extrahepatic biliary system is typically normal. If there's also associated congenital hepatic fibrosis, it's called Caroli's syndrome.
How does Caroli's disease present?
Presentation is variable. It can cause abdominal pain, recurrent bouts of cholangitis due to bile stasis in the dilated segments, or symptoms related to progressive liver disease and portal hypertension. It usually manifests before age 30 and affects males and females equally. A serious complication is the development of cholangiocarcinoma within the dilated ducts.
How's it managed?
It requires a multidisciplinary approach. Cholangitis episodes are treated with antibiotics, and sometimes endoscopic stenting can help drainage. If the disease is limited to one part of the liver, hepatic resection, removing that segment, might be possible. For diffuse disease, especially with significant fibrosis or recurrent complications, liver transplantation is the best option. Unfortunately, recurrence of problems like cholangitis is common, so ongoing surveillance is needed.
And what about colodocal cysts? You mentioned them as a differential for biliary atresia. Figure 71.24 shows the classification.
Right. Colodocal cysts are congenital dilatations that can affect any part of the biliary tree, both inside and outside the liver. Their exact pathogenesis isn't fully understood, but they are often associated with an anomalous junction between the common bile duct and the pancreatic duct, allowing pancreatic enzymes to reflux into the bile duct, potentially causing inflammation and weakening the wall.
How are they classified?
The most widely used classification is the Todani classification, developed by Todani and colleagues. It describes 5 main types based on the location and shape of the dilatation. Type I involves cystic dilatation of the extrahepatic bile duct. This is the most common, accounting for 80–90%. It can be further divided into IA, diffuse cystic, and IB, focal segmental. Type 2 is a true diverticulum, like an outpouching, from the extrahepatic duct, rare, 3%. Type 3 is a choledochocele, a dilatation of the duct segment within the duodenal wall, about 5%. Type 4 involves multiple cysts, either both intra and extrahepatic, IVA, or multiple extrahepatic cysts only, IVB, about 10%. And type V refers to cysts only within the intrahepatic ducts, essentially the Caroli's disease.
How do colodocal cysts typically present?
They can present at any age, but about 60% are diagnosed before the age of 10. The classic triad of symptoms is jaundice, fever pain, cholangitis, and a palpable right upper quadrant mass, but not all patients have all 3. In adults, pancreatitis can be a presenting feature due to the abnormal duct junction.
Is there a cancer risk here too?
Yes, and it's a major concern. There is a significantly increased risk of developing cholangiocarcinoma within the cyst lining. This risk increases with age, making treatment crucial.
How are they diagnosed and treated?
Ultrasound usually confirms the presence of a cyst. MR-MRCP is excellent for fully defining the anatomy, especially the relationship to the pancreatic duct. CT can also show the extent. The treatment of choice for most types, especially I, 2, and 4, is radical excision of the entire cyst, including the gallbladder, followed by reconstruction, usually with a Roux-en-Y hepatocogenostomy to restore bile flow. Complete resection is vital because of the malignancy risk. Type 3 choledochoceles can often be managed endoscopically with a sphincterotomy. It's also important to biopsy the cyst epithelium during surgery to rule out existing dysplasia or cancer.
Okay, shifting gears now from congenital issues to sudden problems like trauma. Is the gallbladder often injured?
Trauma specifically to the gallbladder or bile ducts from blunt or penetrating injuries is actually quite rare. It's more frequent to see iatrogenic injury damage caused inadvertently during other abdominal surgeries, especially cholecystectomy itself, which we'll discuss later.
How would trauma present?
Usually with signs of an acute abdomen peritonitis, pain, tenderness, guarding due to bile leaking into the abdominal cavity. Management really depends on the exact location and extent of the injury.
What are the general principles?
If a major bile duct is transected, the best repair in a stable patient is usually primary reconstruction, using a Roux-en-Y cholecystectomy. Injuries confined to the gallbladder itself are typically dealt with simply by performing a cholecystectomy.
Okay. And what about torsion of the gallbladder? You mentioned that briefly.
Yes, this is a very rare complication. It requires the gallbladder to be unusually mobile, hanging on a long mesentery or stalk, rather than being attached closely to the liver. It's seen more often in older patients, sometimes associated with a mucus seal, which makes the gallbladder heavier.
What are the symptoms?
The presentation is typically sudden, severe right upper quadrant pain because the twisting cuts off the blood supply. It's a surgical emergency requiring urgent exploration and cholecystectomy to remove the dying gallbladder.
All right, now let's move on to the really common stuff. Gallstones or cholelithiasis, you said 10–15% prevalence.
That's right, in Western societies. The source mentions autopsy studies in the UK, finding them in up to 17% of people. They're incredibly common.
But most are silent.
Exactly. It's crucial to remember that the vast majority, over 80%, are asymptomatic. They just sit quietly in the gallbladder and never cause any trouble. Only about 1–2% of people with asymptomatic stones will develop symptoms each year that require surgery. That said, cholecystectomy is still one of the most common operations performed.
So what kind of stones are there? Are they all the same?
No, they generally fall into a few main categories based on their composition: cholesterol stones, pigment stones, which can be black or brown, and mixed stones.
Okay.
Cholesterol and mixed stones are the most common in places like the US and Europe, making up about 80% of cases. These contain anywhere from 50% to almost 100% cholesterol, along with calcium salts, bile pigments, phospholipids, etc.
And pigment stones.
They make up the other 20-30% and contain less than 30% cholesterol. Black pigment stones, which are about 20-30% of all pigment stones, are largely made of an insoluble bilirubin polymer plus calcium phosphate and bicarbonate. These are strongly associated with conditions that cause increased red blood cell breakdown, like hereditary spherocytosis or sickle cell disease, leading to more bilirubin in the bile. They're also seen more often in people with cirrhosis.
And brown pigment stones.
Brown pigment stones are different. They're composed mainly of calcium bilirubinate, calcium palmitate, and calcium stearate, along with some cholesterol. These are more commonly found in the bile ducts rather than the gallbladder itself. Their formation is strongly related to bile stasis and infection, particularly with bacteria that produce an enzyme called beta-glucuronidase. This enzyme deconjugates bilirubin glucuronide in the bile, making bilirubin less soluble and prone to precipitating with calcium. They can also form around foreign bodies like biliary stents or in association with parasitic infections common in Asia, like Clonorchis sinensis, liver fluke, or Ascaris lumbicoides, roundworm.
So how do the common cholesterol stones actually form? Figure 71.25 in the source illustrates this.
It's a fascinating process related to biochemistry. As we said, cholesterol itself is insoluble in water. The liver makes it soluble by packaging it into tiny vesicles, along with phospholipids and bile acids. Think of bile acids and phospholipids as detergents, keeping the cholesterol dissolved.
Okay.
Stones form when this delicate balance is disrupted. Either the liver secretes too much cholesterol, or there aren't enough bile acids or phospholipids to keep it dissolved. This leads to bile becoming supersaturated with cholesterol.
Like sugar in iced tea.
Exactly. Eventually, the unstable cholesterol-rich vesicles start to break down, and cholesterol crystals begin to precipitate out of solution. This initial crystallization or nucleation is a crucial step.
What factors promote this?
Several things. Factors that increase cholesterol secretion into bile include obesity, high-calorie diets, and hormones like estrogen, which is why oral contraceptives can be a factor. Factors that deplete the body's pool of bile acids, like diseases affecting the terminal ileum, where bile acids are reabsorbed, e.g. Crohn's disease, or surgical resection of the ileum, can also lead to lithogenic or stone-forming bile. Furthermore, if the gallbladder doesn't empty properly, gallbladder stasis, these crystals have more time to hang around, aggregate, and grow into macroscopic stones.
And that's why just removing the stones isn't enough.
Precisely. The source stresses that if you just remove the stones but leave the gallbladder, which is either producing or storing this abnormal bile or not emptying properly, the stones will almost certainly recur. You have to address the underlying source of the problem, which usually means removing the gallbladder itself.
Okay, so how do gallstones actually make themselves known when they do cause symptoms?
Often, as we said, they're an incidental finding on imaging done for other reasons. If they do cause symptoms, the classic presentation is pain, often termed biliary colic. It's usually felt in the right upper quadrant, or UQ, of the abdomen or the epigastrium, the pit of the stomach, and it might radiate through to the back, near the right shoulder blade.
Is it really colic like cramping?
That's a bit of a misnomer, as the source points out. It's typically not a cramping, wave-like pain. More often, it's a severe, steady, continuous, dull ache that builds up, lasts for minutes or sometimes hours, and then subsides. It's often accompanied by nausea and sometimes vomiting.
When does it tend to happen?
It frequently starts at night, often waking the patient from sleep. The thinking is that a stone temporarily obstructs the outflow from the gallbladder, usually at the cystic duct, causing the gallbladder to contract against the blockage, leading to pain. The pain resolves when the stone falls back into the gallbladder, relieving the obstruction.
What if it doesn't resolve?
If the obstruction persists and inflammation sets in, that's when you get acute cholecystitis, typically marked by the addition of fever. The source also mentions other symptoms, sometimes associated with gallstones, like dyspepsia, flatulence, fatty food intolerance, or altered bowel habits, but notes their direct link to uncomplicated stones is questionable. Episodes of biliary colic can be infrequent, maybe months or years apart, or they can become quite frequent. Over time, repeated episodes can lead to chronic inflammation and scarring of the gallbladder, resulting in a contracted, non-functioning gallbladder chronic cholecystitis.
When someone comes in with that kind of upper abdominal pain, what else are doctors thinking about? The source has a summary box, 71.3 on this.
Yeah, the differential diagnosis is broad. Common things include appendicitis, especially if the appendix is high-lying, a perforated peptic ulcer, acute pancreatitis, which can actually be caused by gallstones passing into the common duct, or even kidney problems like pyelonephritis. Less commonly, things higher up like pneumonia or even a heart attack, myocardial infarction, can sometimes present with upper abdominal pain. So it's crucial to consider these other possibilities.
Okay. What are the signs a doctor might find, and what are the main complications? Summary box 71.2 covers complications.
If it's progressed to acute cholecystitis, the main sign is tenderness in the right upper quadrant, which is often exacerbated when the patient takes a deep breath while the examiner is pressing there. That's the classic Murphy sign, named after John Benjamin Murphy again. Sometimes, if the inflammation is severe, you might even feel a palpable mass in the RUQ. This is usually the inflamed gallbladder walled off by the omentum, a fatty apron in the abdomen. If the acute inflammation doesn't settle, serious complications can arise. The gallbladder can fill with pus and pyema, the wall can become necrotic, gangrenous, or it can even perforate, leading to a localized abscess or generalized peritonitis.
What about that mucocell you mentioned?
Right. If the cystic duct gets completely blocked by a stone, but there's no significant infection, the bile salts get reabsorbed from the trapped bile, but the gallbladder lining continues to secrete mucus. Over time, the gallbladder distends with this clear mucus, forming a mucocell. It's usually palpable and might cause discomfort, but isn't acutely inflamed.
Can stones cause jaundice?
Yes, if a stone migrates out of the gallbladder, down the cystic duct, and gets stuck in the common bile duct, CBD, it obstructs the flow of bile from the liver, causing bilirubin to back up into the bloodstream, leading to jaundice. Sometimes, a large stone impacted in the cystic duct or gallbladder neck can compress the adjacent common hepatic duct, also causing jaundice. That's part of Morizi syndrome again.
And what about gallstone ileus?
That's a rare but serious complication. It happens when a large gallstone, usually after an episode of severe inflammation, erodes through the gallbladder wall directly into the adjacent bowel, most commonly the duodenum, creating a cholecystoboagnal fistula, an abnormal connection. Small stones might pass through the bowel without issue, but a large stone, typically 2 to 2.5 centimeters, can travel down the intestine and eventually get impacted, causing a bowel obstruction. This usually happens in the narrowest part, the terminal ileum, hence gallstone ileus.
You also mentioned Courvoisier's sign.
Yes, named after Ludwig Courvoisier. This is the finding of a palpable, enlarged, non-tender gallbladder in a patient who is jaundiced. The significance is that this pattern is unlikely to be caused by gallstones blocking the CBD, because chronic inflammation usually makes the gallbladder scarred and non-distensible. Instead, it strongly suggests that the distal CBD obstruction is due to something else, typically a malignancy like pancreatic cancer or cholangiocarcinoma growing around the lower end of the duct.
Okay, that's an important distinction. How is acute cholecystitis formally diagnosed? The source references the Tokyo Consensus Guidelines, Table 71.1.
Right. The Tokyo Guidelines provide diagnostic criteria. It's essentially a clinical diagnosis confirmed by radiology and lab tests. The criteria are grouped into A. Local signs of inflammation, Murphy sign, RUQ pain tenderness mass. B. Systemic signs of inflammation, fever, elevated C-reactive protein or CRP, elevated white blood cell count. And C. Characteristic findings on imaging, like ultrasound.
How are these combined?
A suspected diagnosis requires one item from A plus one item from B. A definite diagnosis requires one item from A, one from B, and supportive findings from C, imaging. Ultrasound is usually the first-line imaging choice, and its accuracy improves when combined with positive clinical and lab findings.
Now, treatment. What about asymptomatic stones? Just leave them alone.
Generally, yes. Since the risk of developing symptoms or complications is low, 1 to 2% per year, prophylactic cholecystectomy isn't usually recommended for truly asymptomatic stones found incidentally.
But there are exceptions.
Yes. The source lists several situations where prophylactic removal is considered, even without symptoms. These include patients with very large stones, for example 3 centimeters, those who already have stones found in the common bile duct, choledoculophiasis, patients with chronic hemolytic conditions like sickle cell disease or hereditary spherocytosis, where pigment stones are common and complications can be severe, those with gallbladder polyps larger than 1 centimeter or other features suspicious for malignancy, patients with an anatomical anomaly like anomalous pancreatic ductal drainage, those with a porcelain gallbladder, due to the potential, though small, cancer risk, individuals from certain ethnic groups or geographical areas with very high rates of gallbladder cancer, patients awaiting organ transplantation, or those undergoing bariatric surgery.
Okay, quite a few exceptions. But for symptomatic stones,
For symptomatic stones, cholecystectomy surgical removal of the gallbladder is a definitive treatment of choice, provided the patient has no major medical contraindications to surgery.
what's the initial approach for someone presenting with acute cholecystitis?
Initial management is typically non-operative, aiming to let the acute inflammation settle down. The source outlines 4 main steps. 1. Nil by mouth NBM and intravenous IV fluids to rest the bowel and maintain hydration. 2. Analgesics for pain relief. 3. Antibiotics, usually broad spectrum, covering common gram-negative aerobic gut bacteria like E. coli. Examples given include cefazolin, eferoxacin, or ciprofloxacin. Achieving good serum concentration is important, especially if the duct is blocked, hindering bile penetration. 4. Subsequent management involves gradually reintroducing oral fluids and diet as the inflammation subsides over a few days.
What about imaging after this initial phase?
After the non-operative treatment, imaging is usually repeated. Ultrasound confirms the diagnosis if it wasn't clear initially. If the patient was jaundiced or had significantly abnormal liver enzymes like ALP, an MRCP is often done to rule out stones that might have migrated into the common bile duct. If there's concern about the diagnosis or potential complications like perforation, a CT scan might be performed.
Then comes the question of when to do the surgery. The source mentions controversy and references the Tokyo guidelines again. Table 71.2 for severity grading, figure 71.26 for a management flowchart.
Yes, the timing of cholecystectomy after an acute attack is debated. One approach is early cholecystectomy, performed during the same hospital admission, ideally within 5-7 days of symptom onset. Studies suggest this is safe when done by an experienced surgeon in a well-equipped facility. It shortens the total hospital stay and avoids potential recurrent attacks while waiting. However, operating in the presence of acute inflammation can be technically more challenging, potentially leading to a slightly higher rate of conversion from laparoscopic to open surgery.
What's the alternative?
The alternative is delayed or elective cholecystectomy. If early surgery isn't performed, the patient is treated non-operatively, discharged home once stable, and brought back for surgery typically around 6 weeks later, allowing the acute inflammation to completely resolve.
How do the Tokyo guidelines help decide?
The guidelines grade the severity of acute cholecystitis. Grade M mild, 2 moderate, 3 severe, based on factors like signs of organ dysfunction, white blood cell count, duration of symptoms, presence of a palpable mass, and extent of local inflammation seen on imaging. They provide a treatment algorithm suggesting management based on severity grade, the patient's overall health and comorbidities, using tools like the Charlson Comorbidity Index, named after Mary Charlson, or the ASA Physical Status Classification from the American Society of Anesthesiologists, and the available facilities and surgical expertise. Generally, milder cases in healthier patients are good candidates for early surgery, while sicko patients or those with more severe inflammation might require initial non-operative management, possibly including gallbladder drainage, with surgery considered later.
What about a calculus cholecystitis inflammation without stones?
Right. This is inflammation of the gallbladder occurring in the absence of gallstones. It presents with a similar clinical picture to calculus cholecystitis, but tends to occur in patients who are already critically ill, perhaps in the ICU after major surgery, trauma, or burns. It's often difficult to diagnose because the patient may be unable to communicate symptoms clearly, and it carries a high mortality rate. Treatment involves supportive care, antibiotics, and often urgent cholecystectomy if the patient can tolerate it. In very sick patients, non-surgical drainage of the gallbladder with a percutaneous tube, cholecystostomy, might be used as a bridge for definitive treatment.
Okay. Beyond acute inflammation, the source mentions a group of conditions called cholecystoses. What are they?
These are relatively uncommon conditions characterized by chronic inflammatory changes and hyperplasia, overgrowth, of the gallbladder tissues. They include cholesterolosis, polyposis, adenomyomatosis, and cholecystitis glandularis proliferans.
Let's take cholesterolosis first. You mentioned strawberry gallbladder. Figure 71.27 shows this.
Yes. Cholesterolosis involves the accumulation of lipids, triglycerides, cholesterol precursors, and esters within macrophages in the gallbladder lining, mucosa. This can appear as tiny yellow flecks, 1 millimeter, giving a granular appearance, or the deposits can aggregate into larger polypoid projections. When these yellow deposits are seen scattered on an inflamed, hyperemic red mucosal background, it gives the appearance of a strawberry, hence the name. It may be associated with cholesterol gallstones.
And cholesterol polyposis.
This is when those cholesterol deposits form distinct polyps. On ultrasound, they appear as non-mobile defects sticking out from the gallbladder wall, crucially without an acoustic shadow behind them, which would suggest a stone. The main differential diagnosis is a true adenomatous polyp, which has malignant potential. So these cholesterol polyps often require follow-up imaging to ensure they aren't growing. Surgery, cholecystectomy, is usually only performed if there's a diagnostic dilemma or if they become symptomatic.
What about cholecystitis, glandularis proliferans, or adenomyomatosis? Figure 71.28 illustrates this.
This condition involves overgrowth of the gallbladder mucosa, thickening of the muscle wall, and the formation of intramural diverticulae or cyst-like structures within the wall, sometimes called Rokitansky-Aschoff sinuses, after Karl Rokitansky and Karl Aschoff. It can affect the gallbladder diffusely or be localized, sometimes forming polypoid projections. While not generally considered premalignant itself, it's clearly associated with cholelithiasis. Complications can include inflammation or abscess formation within these sinuses, potentially leading to fistula. Symptomatic cases are treated with cholecystectomy.
And diverticulosis of the gallbladder, figure 71.29.
This usually manifests as multiple small outpouchings, often containing tiny black pigment stones, developing within the crypts of Luschka we mentioned earlier. It can sometimes be shown on older cholecystography studies as dots of contrast outside the main lumen. Treatment for symptomatic diverticulosis is cholecystectomy.
Okay, let's talk about specific infections involving the gallbladder. Typhoid.
Yes, Salmonella typhi, or typhimurium, the bacteria causing typhoid fever, named after Daniel Salmon, can infect the gallbladder. This can cause acute cholecystitis, but more frequently it leads to a chronic carrier state. The bacteria live in the gallbladder, and the person continuously excretes them in their bile, potentially spreading the infection. Gallstones are often present in carriers, though whether the stones predispose to infection or vice versa is debated. Treatment involves appropriate antibiotics, like ampicillin or quinolone, combined with cholecystectomy to eliminate the carrier state. The source includes a warning note about not giving removed gallstones back to the patient if typhoid is suspected to prevent potential spread.
Good practical point. What about parasites?
Parasitic infestation of the biliary tract is a significant problem in some parts of the world. Biliary ascariasis involves the common roundworm, Ascaris lumbricoides, migrating from the intestine up into the biliary tree via the ampulla of Vater. This can cause severe pain and complications like obstruction, strictures, suppurative cholangitis, pus in the ducts, liver abscesses, or gallbladder empyema. Treatment might involve antispasmodics to relax the sphincter of body, hoping the worm returns to the intestine where it can be treated with anthelminthics. Sometimes ERCP extraction is needed, or surgery for complications.
And clenorchiasis.
This is infection with the Chinese or Oriental liver fluke, Clenorchis sinensis, endemic in the Far East. The fluke lives in the bile ducts, including the smaller intrahepatic ducts. It causes chronic inflammation and fibrous thickening of the duct walls. Complications include pain, secondary bacterial cholangitis, stone formation, often brown pigment stones, cirrhosis, and significantly, an increased risk of bile duct carcinoma, cholangiocarcinoma. The chronic recurrent stone formation associated with this condition, sometimes called Oriental cholangiohepatitis, leads some centers in endemic areas to perform a prophylactic cholecystectomy, with the roux loop brought to the abdominal wall for easy future access for stone removal.
And hydatid disease.
Yes, echinococcus infection. If a large hydatid cyst develops in the liver near the hilum, it can compress and obstruct the hepatic ducts. More dramatically, a cyst can rupture directly into the biliary tree, releasing cyst contents and daughter cysts, causing acute obstruction, jaundice, and severe cholangitis, usually requiring urgent surgical intervention.
Okay, let's revisit gallbladder polyps. Figure 71.40 shows an example. You mentioned they are often incidental findings.
That's right. They are outpouchings from the gallbladder wall found frequently on ultrasound. Most are benign cholesterol polyps, adenomyomas, inflammatory polyps. However, some are true adenomas, which are premalignant, and a small percentage can be malignant from the start, usually adenocarcinoma, about 80% of malignant polyps, but occasionally squamous cell or cystadenocarcinoma. Most polyps are stable and don't grow.
So how are they managed? When do they need surgery?
Cholecystectomy is indicated for any symptomatic polyp. Prophylactic cholecystectomy is recommended to mitigate the risk of malignancy in several situations.
Yeah.
If the patient also has gallstones, if they have primary sclerosing cholangitis, PSC, or if they experience biliary colic or pancreatitis even without stones. Specific features of the polyp itself also warrant removal. Patient age over 50. A polyp that is sessile, flat-based rather than on a stalk, especially with associated gallbladder wall thickening, 4 mm, or simply size greater than 10 mm. Smaller polyps 10 mm without these risk factors are typically observed with serial ultrasounds. Surgery is recommended if they show significant growth.
What about xanthogranulomatous cholecystitis? You mentioned it earlier as mimicking cancer, figure 71.3U.
Yes, XGC is an uncommon but destructive inflammatory process affecting the gallbladder wall. It seems to be more frequent in places like India and Japan and more common in females. The cause is thought to involve bile extravasating into the gallbladder wall, perhaps from ruptured Rokitansky-Aschoff sinuses or mucosal ulcers. This triggers an intense inflammatory reaction with lipid-laden macrophages, xanthoma cells, fibrosis, and other inflammatory cells, leading to marked thickening and destruction of the wall.
What does it look like on imaging?
On ultrasound, it typically shows diffuse or focal gallbladder wall thickening, often with characteristic intramural hypoechoic nodules or bands. Gallstones are usually present. CT scans often show hypoattenuating nodules within the thickened wall, poor or heterogeneous contrast enhancement, and sometimes early enhancement of the adjacent liver tissue. The problem is that these features, especially the wall thickening and potential extension into the liver or involvement of lymph nodes, can look very similar to gallbladder carcinoma.
So it's hard to tell apart from cancer.
Extremely difficult preoperatively. The definitive diagnosis often relies on pathological examination of the removed gallbladder, sometimes requiring a frozen section during surgery. Because of this difficulty in differentiation, and the fact that cancer can coexist with XGC, reports range from 2.3% to 13.3%, and open cholecystectomy is often considered the safer approach if XGC is suspected before surgery to ensure adequate resection if cancer is present.
Okay, let's discuss gallstones, specifically in pregnancy. You mentioned it's a common issue.
Yes, acute cholecystitis is actually the second most common non-obstetric surgical emergency during pregnancy, after appendicitis.
Why is it more common in pregnancy?
Hormonal changes are the main culprit. Increased estrogen levels lead to increased cholesterol secretion into bile, making it more supersaturated. Progesterone reduces bile acid secretion and also slows gallbladder emptying stasis. This combination of supersaturated bile and stasis significantly increases the risk of stone formation. Other risk factors like pre-pregnancy obesity, having had multiple pregnancies, multiparity, older maternal age, and genetic predisposition also play a role.
Are there specific things to consider when a pregnant woman has RUQ pain?
Absolutely. Besides biliary colic or cholecystitis, other serious pregnancy-related conditions can present with similar pain. These include severe preeclampsia or HELP syndrome, hemolysis, elevated liver enzymes, low platelets, acute fatty liver of pregnancy, placental abruption, uterine rupture, or intraamniotic infection. So a thorough evaluation is crucial. For imaging, ultrasound is the primary tool. Non-contrast MRI is also considered safe if needed.
How is treatment managed based on the trimester?
In the first trimester, if symptoms are mild, conservative management, pain relief, diet modification is often the mainstay. NSAIDs can be effective analgesics, but are generally avoided late in pregnancy after 32 weeks due to potential effects on the fetal ductus arteriosus. In the second trimester, women with moderate to severe symptoms who are otherwise good surgical candidates, ASA class 1 or R, are often recommended to undergo cholecystectomy during that same hospitalization. This is because the risk of recurrent attacks and complications is high if surgery is delayed. In the third trimester, non-operative medical management, antibiotics, fluids, pain relief, is usually preferred initially due to the risks of surgery close to term. The plan is typically to reevaluate the need for cholecystectomy after delivery, usually waiting about 6 weeks postpartum.
Okay, makes sense. Now back to gallstone ileus. You said it's infrequent.
Yes, a rare complication of gallstones may be occurring in about 1.4% of patients with cholelithiasis. It's more common in the elderly and in women.
Remind us how it happens again.
It typically starts with an episode of acute cholecystitis, where the inflamed gallbladder wall erodes into an adjacent part of the bowel, usually the duodenum, forming a cholecystoenteric fistula. Bile and small stones might pass through this fistula without issue, but if a large stone, usually 2 to 5 centimeters, passes through, it can travel down the small intestine until it gets stuck, causing a mechanical bowel obstruction.
Where does it usually get stuck?
Most commonly in the terminal ileum or at the ileocecal valve, simply because this is the narrowest part of the small bowel and peristalsis is less vigorous there. Less commonly, a stone might impact in the stomach outlet or duodenum, causing gastric outlet obstruction, a specific type called Bouvere's syndrome, after Leon Bouveret. Wherever it impacts, the stone can cause pressure necrosis, perforation, and peritonitis if not treated promptly.
How does gallstone ileus present clinically?
It can be tricky. Symptoms might be acute, intermittent if the stone moves a bit, or chronic, reflecting partial or complete bowel obstruction. The physical exam findings might be nonspecific or show classic signs of obstruction like dehydration, abdominal distension, tenderness, high-pitched bowel sounds initially, and potentially obstructive jaundice if the fistula involves the bile duct.
How is it diagnosed on imaging?
A plain abdominal radiograph might show the classic Wriggler's triad, named after Leo Wriggler, that consists of 1. Signs of small bowel obstruction, dilated loops, air fluid levels. 2. Air within the biliary tree, pneumobilia because of the fistula. And 3. Visualization of the aberrant gallstone itself, if it's calcified enough. Sometimes you might see that the stone has changed position on serial films, known as the tumbling sign. However, CT is far superior for diagnosis, with sensitivity up to 93%. CT clearly shows the level of obstruction, the ectopic stone, and often the abnormal gallbladder, perhaps with air or an air fluid level, and the fistula itself.
What's the management?
The primary goal is to relieve the intestinal obstruction. The most common surgical procedure is an enterolithotomy, making an incision in the bowel, usually just proximal to the impacted stone where the bowel is healthier, manipulating the stone back to that spot if necessary and extracting it. The intestinal incision is then closed. Whether to address the cholecystoenteric fistula at the same time is debated. Often, especially in frail elderly patients, the fistula is left alone, as closing it adds significant time and complexity to the surgery. However, leaving it carries a risk of recurrent gallstone ileus or ongoing biliary symptoms, so some advocate for a single-stage procedure, enterolithotomy plus a cholecystectomy and fistula closure, in stable, younger patients, or a staged approach later.
Okay, now let's talk about the definitive treatment for most gallbladder problems, cholecystectomy. What's involved in preparing a patient? The source has a summary box, 71.4 on this.
Right. Preparation involves several key steps. Taking a thorough history, specifically asking about any history of jaundice, which might suggest common bile duct stones. Assessing the patient's overall fitness for surgery, including cardiac and respiratory status. Basic laboratory tests are essential. A full blood count, FBC, renal function tests, liver function tests, LFTs, and coagulation studies like prothrombin time, PT. Depending on age and comorbidities, a chest X-ray or ECG might be needed. Crucially, obtaining informed consent is vital, explaining the planned procedure, alternatives, potential risks, and common complications. Prophylactic antibiotics, often a second-generation cephalosporin given at the time of anesthesia induction, are standard practice to reduce wound infection risk. And finally, measures to prevent deep vein thrombosis, DVT, such as subcutaneous heparin and anti-embolic stockings are important, especially for higher-risk patients.
Are there ways to predict if a cholecystectomy might be difficult? Table 71.3 lists some predictors.
Yes, several factors can suggest a potentially challenging operation. From the patient's history, being male, being older, for example 65, presenting late after symptom onset, having had multiple previous attacks of cholecystitis, previous upper abdominal surgery, or having had a previous attempt at cholecystectomy or a cholecystostomy tube placed.
What about imaging findings?
Imaging signs suggesting difficulty include a very thick-walled gallbladder, a shrunken fibrotic gallbladder, chronic cholecystitis, a massively distended gallbladder, a large stone impacted in the gallbladder neck or cystic duct, signs of gangrene or perforation, findings suggestive of Moritzi syndrome or a fistula, or the presence of liver cirrhosis with portal hypertension, which increases bleeding risk.
And intraoperative findings.
Things discovered during the operation itself, like a shrunken gallbladder embedded in dense adhesions or unexpected liver issues. Physical exam findings like morbid obesity or a high ASA score, indicating significant comorbidities, also predict potential difficulty. And abnormal LFTs can sometimes correlate with more severe inflammation. Recognizing these predictors helps the surgeon plan appropriately, anticipate challenges, and counsel the patient.
It's also critical to assess the risk of having stones in the common bile duct, CBD, right? Table 71.4 covers risk factors.
Absolutely. Finding and dealing with CBD stones is a key part of managing gallstone disease. Risk factors include a history of jaundice, cholangitis, or gallstone pancreatitis. Abnormal LFTs, particularly elevated bilirubin or alkaline phosphatase, are strong predictors. And on ultrasound, a dilated common bile duct, generally 6 millimeters in diameter, raises suspicion and requires further evaluation. Based on these factors, patients can often be stratified into low, medium, or high risk for having CBD stones.
What determines the next step?
Low-risk patients, maybe 2-3% chance of CBD stones, might proceed directly to cholecystectomy, perhaps with consideration for intraoperative cholangiography. Medium-risk patients, 20–40% chance, usually warrant further investigation, typically with MRCP, before surgery. High-risk patients, 50–80% chance, often undergo preoperative ERCP to confirm and remove CBD stones before cholecystectomy.
Okay, let's talk about the procedure itself. Laparoscopic cholecystectomy is the standard now, correct?
Yes, for the vast majority of patients, laparoscopic or keyhole surgery is the procedure of choice. The indications and preparation are essentially the same as for open surgery.
How is it performed?
The patient is positioned supine, under general anesthesia. A pneumoperitoneum is created. The abdomen is inflated with carbon dioxide gas to create working space. The source mentions the open Hassan technique, a small cut down usually near the umbilicus, as a preferred method for initial access, though using a Ver's needle is another common way to insufflate gas. A camera, usually an angled laparoscope, 30 degrees is preferred for better views around corners, is inserted through this first port. The source briefly mentions single-port laparoscopic surgery, but notes review suggest higher failure rates, longer operating times, more blood loss, and no clear substantive benefits over standard multi-port laparoscopy.
What are the key surgical steps in the laparoscopic approach? Figure 71.31 shows the setup, and Table 71.5 lists tenets for safety.
After initial access, additional small ports, usually 5mm or 10mm, are placed under direct vision, typically one below the Dibble-Weitvoigt process, and one or two along the right subcostal margin for inserting instruments. The operating table is tilted into a reverse Trendelenburg position, head up, and slightly rotated to the left to let gravity help move the bowel out of the way. Graspers are used to retract the gallbladder. The fundus is pulled towards the patient's right shoulder, and the infundibulum, Hartmann's pouch area, is pulled inferolaterally towards the right iliac fossa. This maneuver helps to open up an exposed callus triangle.
And the dissection starts there.
Yes. The absolute key to safe laparoscopic cholecystectomy is meticulous identification and safe dissection within callus triangle, or the hepatocystic triangle. The surgeon carefully lays this area open by dividing the overlying peritoneum, both the anterior and posterior layers. Then, careful blunt dissection is used to define the cystic duct and the cystic artery where they enter the gallbladder. It's crucial to separate the gallbladder partially from the liver bed for about 2 centimeters near the neck, exposing the cystic plate, to confirm that only these two structures are connecting the gallbladder.
Is intraoperative cholangiography routinely done?
Practice varies. Routine cholangiography isn't always performed, but it's definitely warranted if the anatomy is unclear or if there's a moderate suspicion of CBD stones. The source also mentions real-time ICG, indocyanine green, fluorescence cholangiography, as a newer technique that can help visualize the bile ducts during surgery and potentially reduce injury rates.
What happens once the anatomy is clear?
Once the surgeon is confident they have achieved the critical view of safety, meaning the triangle is cleared and only the cystic duct and cystic artery are seen entering the gallbladder. Then surgical clips are applied to the cystic duct and artery, and they're divided between the clips. The gallbladder is then carefully dissected away from its bed on the undersurface of the liver using cautery or other energy devices. Finally, the detached gallbladder is placed in a retrieval bag and removed from the abdomen, usually through the umbilical port site.
What if laparoscopy isn't possible or safe? Then it's open cholecystectomy.
Correct. This is used either as a planned procedure if laparoscopy is contraindicated, for example, due to severe adhesions from previous surgeries or medical conditions, or if the surgeon needs to convert from a laparoscopic approach due to difficulty or complications encountered during the keyhole procedure.
What kind of incision is used?
Several options. A common one is an upper midline incision. A short right subcostal incision, Kocher incision after Emil Kocher, is also frequently used. Alternatively, a right upper transverse incision can provide good access.
How does the open procedure differ?
Once the abdomen is open, the gallbladder is exposed. Packs are used to gently hold the surrounding organs, like the hepatic flexure of the colon, the duodenum, and the stomachus or omentum. Out of the way, the source quotes Moynihan saying the assistant's left hand is the best retractor here. Forceps, perhaps Duval forceps after Pierre Duval, are placed on the gallbladder infundibulum to provide traction. This stretches the peritoneum overlying callus triangle, which is then carefully incised close to the gallbladder wall. Gentle dissection, often using a swab, clears away fat and connective tissue to expose the cystic artery and cystic duct clearly. It's vital to trace the cystic duct down towards the common bile duct to be absolutely sure of the anatomy and avoid mistaking the CBD for the cystic duct. The cystic artery is identified, ligated, tied, or clipped, and divided. The entire callus triangle should be displayed clearly. The cystic duct is then ligated or clipped close to the gallbladder and divided. Figure 71.32 shows ligation. Finally, the gallbladder is dissected from the liver bed, usually starting from the neck and working toward the fundus.
The source lists several tenets for safe cholecystectomy in table 71.5. Let's go through those, as they seem crucial for achieving that professional level of understanding we're aiming for.
Absolutely. These principles apply to both laparoscopic and open surgery. First is the concept of the safe zone of dissection. This emphasizes staying cephalad towards the head, relative to the R4U line, Rouvier sulcus segment feet umbilical fissure that we discussed earlier. It also warns against zooming in too much with the laparoscope, which can lead to loss of crucial anatomical landmarks. Dissection posterior to the head of the cystic triangle should start ventral and cephalad to Rouvier sulcus. The source mentions the Be Safe method, bile ducts, sulcus of Rouvier, hepatic artery invariants, fissures of Gans, and duodenum as a useful cognitive mapping tool for orientation.
Okay, stay oriented, stay in the safe zone. What's next?
The concept of a timeout. This isn't just at the start of the case, but a cognitive aid during difficult parts of the surgery. It means consciously pausing, reorienting, recalling the key anatomical landmarks and safety measures, and ensuring you haven't drifted into a danger zone. It helps prevent task fixation or disorientation from leading to injury.
Makes sense to pause and reset. What about energy sources?
Judicious use of energy sources is critical. With monopolar cautery, like a hook cautery commonly used laparoscopically, the advice is to use a low power setting, VG30W. Divide only small amounts of tissue at a time after gentle traction, avoiding injury from the heel of the instrument. Use intermittent short bursts to minimize lateral thermal spread, and absolutely avoid blind use of cautery, especially when there's bleeding. Ultrasonic energy devices generally have less lateral thermal spread, but their jaws can sometimes be cumbersome in the tight confines of the hepatocystic triangle.
Okay, careful with the heat. Then there's the critical view of safety.
Yes, the concept of the critical view of safety, CVS, is arguably the cornerstone of preventing bile duct injury, particularly in laparoscopy. The goal is conclusive identification of the cystic duct and cystic artery before they are clipped or cut. This requires 3 criteria to be met. 1. The hepatocystic triangle must be cleared of all fat and fibrous tissue, leaving only 2 structures visible. 2. The lower third of the gallbladder must be separated from the liver bed, the cystic plate, to ensure you can see the base of the gallbladder clearly. 3. Only 2 structures should be seen entering the gallbladder itself, presumed to be the cystic duct and cystic artery. Achieving this view provides strong evidence against misidentification of the common bile duct as the cystic duct.
What if you can't achieve that clear view?
That leads to the next tenet, stopping rules. This means recognizing red flag situations during dissection, things like severe adhesions or inflammation making landmarks obscure, a large impacted stone in the gallbladder neck distorting the anatomy, Moritzi syndrome, or chronic fibrosis and scarring. These signs indicate a significantly increased risk of bile duct injury, and the surgeon needs to recognize them and stop the standard dissection before causing harm.
And what should they do when they stop?
That's where calling for help or a second opinion comes in. The source emphasizes this is an important sign of good surgical practice and judgment, not ineptitude. Getting another experienced surgeon to look can be invaluable in a difficult situation.
Okay. And if, even with help, safe dissection isn't possible?
Then you move to bailout techniques or strategies. These are alternative procedures employed specifically for safety when achieving the critical view or completing the cholecystectomy dissection is deemed too hazardous. The source lists 5 main strategies. 1. Simply abort the procedure and plan for later management. 2. Convert to an open cholecystectomy, ideally as a planned decision early on, not forced by a complication. 3. Perform a tube cholecystostomy, placing a drainage tube, like a Foley catheter after Frederick Foley, into the gallbladder. 4. Perform a subtotal cholecystectomy, removing most of the gallbladder but leaving a small portion of the wall, especially the posterior wall attached to the liver or the area around the duct junction, in place. 5. Use a fundus first dissection approach, starting dissection from the top fundus of the gallbladder down towards the hilum, which can sometimes be safer in inflamed cases. The choice depends on the specific situation and the surgeon's experience. Conversion to open should be seen as a tool for safety, not a failure.
Those safety tenets seem incredibly important. What about complications after cholecystectomy?
Complications can occur in about 10–15% of cases overall, though most are minor. Laparoscopic surgery generally leads to faster recovery and less pain, with many elective patients going home the same day. Postoperative fever, chills, or worsening pain should prompt close observation and investigation. Serious complications include issues related to access, like bowel or vessel injury during port placement, and, most significantly, bile duct injuries.
How common are bile duct injuries?
Fortunately, they are rare, occurring in roughly 0.5% of laparoscopic cholecystectomies, but they are a major source of morbidity. What's the main cause?
The source states the main cause is usually poor dissection technique and failure to correctly identify the biliary anatomy before dividing structures. There's ongoing controversy about whether routine use of intraoperative cholangiography reduces the injury rate. Most surgeons currently use it selectively based on risk factors or unclear anatomy. Overall operative mortality for cholecystectomy is low, less than 1%, but the risk increases with patient age, comorbidities, and if the surgery is done emergently for acute cholecystitis.
What happens if a patient develops jaundice after surgery?
Postoperative jaundice needs urgent investigation and should never be simply attributed to cholangitis without proof. The first steps are resuscitation if needed, broad-spectrum antibiotics, and an urgent ultrasound to look for ductal dilatation. The definitive anatomy of the biliary tree and any potential injury is best defined by MRCP, potentially supplemented by ERCP. ERCP is particularly useful when therapeutic maneuvers are planned, like removing retained stones or placing a stent across a bile leak or stricture. If a fluid collection, like a bilomate collection of bile, is seen under the liver, it usually requires drainage, often guided by radiology, but sometimes requiring open surgery. Small bile leaks, especially from the cystic duct stump, often resolve spontaneously if there's no blockage further down the duct, but major CBD damage requires expert surgical reconstruction.
How do these bile duct injuries typically declare themselves?
Only about 15% are recognized at the time of the initial surgery. The rest present postoperatively. This might be as a profuse or persistent bile leak from an abdominal drain, if one was placed, or as bile peritonitis if no drain was placed and bile collects freely in the abdomen. Alternatively, the patient might develop deepening obstructive jaundice if the duct was completely ligated or severely damaged. If the obstruction is incomplete, jaundice might be delayed for weeks or months until fibrosis and scarring cause the lumen to narrow significantly as stricture.
How are these suspected injuries investigated?
Ultrasound is usually the first step, looking for fluid collections, CBD dilation, or possibly related vascular lesions. CT can also show focal fluid collections, ascites, fluid in the abdomen, the level of obstruction and dilation, and can also assess long-term consequences like hepatic atrophy or secondary biliary cirrhosis. CT angiography might identify an associated vascular injury, particularly to the right hepatic artery, RHA, which often runs close to the cystic duct. MRCP is considered the gold standard for morphological evaluation, clearly defining the level and degree of injury, often using classifications like the Strasberg classification. MRCP combined with angiography, MRCPA, is used if vascular injury is suspected. A HIDA scan can confirm an active bile leak or demonstrate obstruction. ERCP is both diagnostic, showing the leak site, duct continuity, type of injury, residual stones, and therapeutic. The most common leak is from the cystic duct stump, which can often be successfully treated by placing an ERCP stent across the leak origin into the CBD. What about surgical repair? Figure 71.33 shows the Strasberg classification.
Surgical repair and the ultimate outcome are highly dependent on the level and degree of the bile duct injury, as classified by systems like Strasberg. Types E1, E6 involve various transections or strictures relative to the hilum, including aberrant ducts. Note E6 wasn't in the original classification, but is shown. Concomitant vascular injury significantly worsens the prognosis. The principles of repair are to maintain as much duct length as possible and restore unobstructed bile drainage into the intestine. For a recent stricture, if a guide wire can be passed, balloon dilatation and stenting via ERCP might be attempted by an experienced endoscopist. However, for established benign strictures or complete duct transections, the preferred treatment is surgical reconstruction with a Roux-en-Y hepatic schistostomy, ideally performed by an experienced hepatobiliary surgeon at a specialist center.
What factors predict a poor outcome after injury?
Factors associated with poor prognosis include the presence of bile peritonitis at the time of diagnosis, combined vascular and bile duct injuries, and injuries occurring high up at or above the biliary bifurcation. These injuries have a significant negative impact on patients' long-term quality of life and ability to work.
What if patients have persistent symptoms after cholecystectomy, the so-called post-cholecystectomy syndrome?
This term describes the situation where patients, up to 15% according to the source, fail to get relief from their original symptoms after gallbladder removal or develop new ones. Often it's a continuation of symptoms that were perhaps incorrectly attributed to the gallbladder in the first place. However, it's crucial to perform a detailed history and full investigation to exclude specific surgically related causes, like a retained stone in the common bile duct, a stone that formed in the cystic duct remnant stump, or subtle operative damage like a stricture. MRCP and ERCP are key investigations here, with ERCP allowing for stone removal if found. What about post-cholecystectomy cholangiography? Figure 71.34, 71.35, 71.36 relate to this.
This refers specifically to stones found or formed in the common bile duct after the gallbladder has been removed. This can happen if there's some obstruction to bile flow lower down, leading to stasis and new stone formation within the duct itself. These might appear years after the original surgery and can be related to new pathology like infection, parasites, Ascaris clonorchis, or strictures. The consequence is either obstruction or infection, cholangitis. Duct stones are actually more often associated with infected bile, around 80%, compared to gallbladder stones.
How do these duct stones present?
They might be asymptomatic, found incidentally, or they can cause symptoms, classically cholangitis, presenting with bouts of pain, often RUQ or epigastric, jaundice, and fever chills, the classic Charcot's triad, named after Jean-Martin Charcot. On examination, the patient might be febrile, icteric, jaundiced, and have tenderness in the epigastrium or RUQ.
What's the management?
First, confirm the jaundice is obstructive using LFTs and ultrasound. MRCP helps define the nature and location of the stones. If cholangitis is present, there might be pus in the biliary tree or even liver abscesses. Management requires prompt resuscitation, fluids, checking clotting factors, as liver dysfunction can affect them, ruling out diabetes, which worsens infection risk, and starting broad-spectrum antibiotics. But the essential step is relief of the obstruction. How is that usually done?
The preferred method nowadays is endoscopic via ERCP. This involves performing an endoscopic papillotomy or sphincterotomy, cutting the muscle at the lower end of the bile duct to widen the opening, followed by stone removal using instruments like a wire basket, Dormia basket after Enrico Dormia, figures 71.34, 71.35, or an extraction balloon, sometimes a temporary stent or a nasobiliary drain, a tube through the nose into the bile duct is placed.
What if ERCP fails?
If ERCP is unsuccessful or unavailable, the next step might be PTC for drainage, potentially followed by percutaneous cholecystectomy and stone removal using the track, as we discussed, for hand technique. Surgical exploration, cholecystectomy opening the common bile duct, is rarely needed for simple stone removal anymore. Can you describe cholecystectomy, even if rare?
Sure. If surgery was required, it involved performing a laparotomy, opening the abdomen, exposing the common bile duct, and making a longitudinal incision in the duct wall to remove the stones, often under direct vision or with the help of on-table cholecystectomy to confirm clearance. Historically, a T-tube drain, figure 71.36, was often inserted into the duct before closing it. The T-tube allowed bile to drain externally initially. A cholangiogram could be done through the tube later. If residual stones were seen, the tube was left in place for about 6 weeks to allow a mature tract to form. A radiologist could then use this tract to remove the stones percutaneously, the Berhen technique again. The tract usually closes spontaneously after the tube is removed. Nowadays, residual small stones are almost always dealt with endoscopically.
Okay. Besides stones and surgical injury, what else causes benign biliary strictures? Summary box 71.5 lists causes.
Several possibilities. Congenital causes like biliary atresia. Bile duct injury is a major one, not just from cholecystectomy, but also after cholecystectomy, gastrectomy, hepatic resection, or liver transplantation. Inflammatory causes are important too, chronic inflammation from stones themselves. Colonocolithiasis, recurrent cholangitis, parasitic infections, chronic pancreatitis squeezing the duct, primary sclerosing cholangitis, PSC, or even radiotherapy to the area. Trauma is another cause, and sometimes they are idiopathic, no clear cause found.
And investigations for strictures, summary box 71.6.
The usual suspects. Ultrasound first, then ARCP provides excellent anatomical detail. ERCP is often crucial, especially if a biopsy, brush cytology, or therapeutic intervention, dilation, stenting, is needed for a dominant stricture. PTC might be needed if ERCP axis is blocked. CT helps assess the surrounding structures and rule out malignancy.
Let's talk about primary sclerosing cholangitis, PSC. Figure 71.37 shows the characteristic beating.
Right. PSC is a rare idiopathic, meaning cause unknown, progressive disease. It's characterized by chronic inflammation, fibrosis, scarring, and eventual destruction of both the intrahepatic and extrahepatic bile ducts. This leads ultimately to biliary cirrhosis and liver failure. There seems to be an immunological basis, suggested by associations with hypergammaglobulinemia, autoantibodies like anti-smooth muscle or anti-nuclear factor, and possibly mutations in genes like CFTR, the cystic fibrosis gene. It typically affects people aged 30-60 with a male predominance.
And the link with IBD.
Yes, there's a very strong association with inflammatory bowel disease, particularly ulcerative colitis, UC. About 80% of patients with PSC also have IBD, and conversely, about 5% of patients with UC develop PSC.
How does PSC present clinically?
It can be asymptomatic initially, often picked up on routine liver tests. When symptoms develop, they often include fatigue, pruritus itching, intermittent fever or chills, cholangitis, right upper quadrant discomfort, jaundice, and weight loss. LFTs typically show a cholestatic pattern, markedly elevated alkaline phosphatase, ALP, and gamma-glutamyl transpeptidase, GGTP, with smaller rises in aminotransferases, STALT. Bilirubin levels can be variable, but rise as the disease progresses.
How is it diagnosed?
Diagnosis is usually made based on the characteristic cholangiographic findings on MRCP or ERCP, which show multiple strictures and segmental dilatations throughout the biliary tree, giving it a beaded appearance. Liver biopsy isn't always necessary for diagnosis if the cholangiogram is typical, but it can help confirm the diagnosis, looking for the classic onion skinning periductal fibrosis, stage the degree of liver fibrosis cirrhosis, and guide therapy.
What are the main differential diagnoses?
Important to exclude secondary causes of sclerosing cholangitis, like from stones, surgery, or ischemia, IgG4-related cholangitis, which we'll mention, autoimmune hepatitis overlap, HIV cholangiopathy, and crucially, cholangiocarcinoma, as PSC patients are at high risk. Any dominant stricture or unexplained deterioration in a PSC patient should raise high suspicion for malignancy.
What are the major complications and management strategies?
As mentioned, the main complications are progressive liver disease leading to cirrhosis and liver failure, and the significantly increased risk of developing cholangiocarcinoma, bile duct cancer. There's also an increased risk of gallbladder cancer, and in those with concurrent IBD, colon cancer. Medical management focuses on symptom control, antibiotics for cholangitis, vitamin K for clotting issues, cholestyramine for itching. Drugs like steroids or immunosuppressants haven't shown clear benefit in slowing disease progression. Endoscopic therapy, balloon dilatation, stenting can be used for dominant strictures causing significant blockage. Operative resection might be considered for predominantly extrahepatic disease in highly selected patients, but it's uncommon. Ultimately, liver transplantation is the best option for patients with end-stage liver disease due to PSC, with excellent outcomes, 80% 5-year survival, reported in high-volume centers. What about screening?
Critical. Given the risks, regular screening is mandatory. This includes surveillance for gallbladder polyps cancer and bile duct malignancy, often with annual imaging like MRA-MRCP and possibly CA19-9 tumor marker checks, regular colonoscopy for those with IBD to screen for dysplasia colon cancer, and bone densitometry scans to monitor for osteoporosis, which is common due to chronic cholestasis and a potential steroid use.
You mentioned IgG4-related cholangitis.
Yes, this is a relatively recently recognized condition that can mimic PSC, cholangiocarcinoma, or even pancreatic cancer. It's part of a systemic fibroinflammatory condition associated with elevated serum IgG4 levels and often involves other organs, autoimmune pancreatitis, celladinitis, retroperitoneal fibrosis. Biliary biopsies show a characteristic lymphoplasmacytic sclerosing cholangitis with abundant IgG4 positive plasma cells. The key difference is that it often responds dramatically to systemic steroid therapy. Failure to respond should prompt reconsideration of the diagnosis and exclusion of malignancy.
Okay, let's move on to tumors of the bile duct. Are benign tumors common? No, benign tumors like papillomas, adenomas, granular cell tumors, leiomyomas, or neuroendocrine tumors are uncommon. They might be found incidentally or cause symptoms by obstructing the duct. Symptoms, if present, usually develop over days to months.
What about intraductal papillary neoplasm of the bile duct, IPNB?
This is a rarer variant, considered the biliary counterpart to IPMN in the pancreas. It involves papillary growths within the bile duct lumen, often causing ductal dilatation and producing mucin. It represents a spectrum from pre-malignant dysplasia to invasive cholangiocarcinoma. Imaging, USG, CT, MRI, shows the dilated ducts and intraductal masses. Cholangioscopy can help confirm the diagnosis histologically and assess the extent of spread along the duct surface. Treatment, if there's no distant metastasis, involves surgical resections similar to that for cholangiocarcinoma, often requiring major hepatectomy and or extrahepatic bile duct resection.
Now, the malignant ones, bile duct cancer or cholangiocarcinoma, summary box 71.7 covers this.
Right. This is a malignancy arising from the epithelial lining of the bile ducts. It can occur anywhere along the biliary tree, from the small intrahepatic ducts down to the ampulla. Pathologically, it can be mass-forming, grow along the duct lining, interductal growing, or infiltrate along the duct wall, periductal infiltrating. While rare overall, its incidence seems to be increasing. It typically peaks in the 8th decade of life and has a slight male predominance, around 1.5.1.
How is it classified anatomically?
Commonly classified by location. Intrahepatic, starting within the liver ducts, about 10-20%. Hilar or parahilar, at the junction of the right and left hepatic ducts, also called Klatskin tumors, after Gerald Klatskin, the most common type at 60%. Or distal, in the lower common bile duct, 20-30%.
What are the known risk factors? Summary box 71.8 lists them.
Interestingly, the majority of patients have no identifiable risk factor. However, several conditions are strongly associated. In Western countries, the major risk factor is primary sclerosing cholangitis, PSC, which carries about a 20-fold increased risk and tends to present at an earlier age, 30 to 50. Other risks include congenital cystic diseases, like colodocal cysts and Caroli's disease, hepatolithiasis, stones within the liver ducts, chronic biliary inflammation from liver fluke infections common in Asia, Opisorchis viverini, Clinorchus sinensis thought to cause chronic inflammation, DNA damage, release carcinogens, promote cell proliferation, exposure to certain chemical agents like thorotrast, vinyl chloride, dioxins, asbestos, prior bilioenteric anastomosis surgery, and possibly non-alcoholic fatty liver disease.
How do these patients typically present?
Early symptoms are often vague and nonspecific, like dull abdominal pain, early satiety, loss of appetite, anorexia, and weight loss. Symptoms specifically related to biliary obstruction, like itching, pruritus, and jaundice, often occur later, unfortunately meaning the disease is frequently advanced at diagnosis. On examination, findings might include jaundice, signs of weight loss, cachexia, and potentially a palpable gallbladder if the obstruction is distal, for Weissier's sign again. Late presentation is common.
What investigations are done?
Biochemical tests confirm obstructive jaundice, elevated bilirubin, ALP, GGTP. The tumor marker CA19-9 is elevated in about 80% of patients, but it's not specific enough for diagnosis alone. Imaging is essential for diagnosis, staging, and determining resectability. Ultrasound is often the first test. High-quality contrast-enhanced CT, or MR-MRCP, figure 71.38 shows an example, are crucial to define the level of obstruction, the local extent of the tumor, including vascular involvement, especially the portal vein and hepatic artery, and to look for regional lymph node involvement or distant metastases, for example, in the liver or peritoneum.
What about direct cholangiography, like ERCP or PTC?
These are usually performed after non-invasive imaging has suggested the diagnosis. Their roles are to precisely define the level and length of the obstruction, allow for tissue sampling, biopsy, or brush cytology, though these can have false negatives in 40-80% of cases, and importantly, to place an endobiliary stent for palliative drainage of bile if needed. The choice between ERCP and PTC depends on availability and the location of the tumor. PTC is better for proximaliar tumors, ERCP for distal ones. Preoperative biliary drainage is often necessary before major liver resection if the patient is significantly jaundiced, for example, bilirubin 6 mg/dL, because severe jaundice impairs liver regeneration. Cholangioscopy, performed via ERCP, can be a useful adjunct for direct visualization and targeted biopsies, increasing diagnostic accuracy.
How is cholangiocarcinoma staged?
Staging is critical for determining treatment options and prognosis. Anatomical extent, particularly for hilar tumors, is often classified using the Bismuth-Corlett classification. Figure 71.39 shows this. This categorizes tumors from type I below the confluence to type 4, involving secondary branches on both sides, based on how far up the biliary tree the tumor extends. The Memorial Sloan Kettering Cancer Center, MSKCC, has also proposed staging criteria incorporating T-stage, tumor invasion depth extent, including involvement of confluence, second-order radicals, portal vein invasion, or associated hepatic atrophy. What is the treatment and prognosis?
Management requires a multidisciplinary team approach. Unfortunately, the majority of patients present with advanced unresectable disease, so treatment is often palliative. Surgical resection offers the only potential for long-term survival, but is only feasible in about 10-15% of patients. What makes a tumor resectable?
Resectability depends on several factors. Patient factors: overall health, comorbidities, presence of underlying chronic liver disease, and tumor factors: extent of spread within the biliary tree, involvement of critical blood vessels like the portal vein or hepatic artery, the volume of the future liver remnants. Sometimes portal vein embolization is needed to enlarge the future remnant, and crucially, the absence of distant metastases.
What does surgery involve?
For hilar cholangiocarcinoma, surgery typically involves a major hepatic resection, removing part of the liver, along with excision of the caudate lobe, which often drains directly into the confluence, en bloc lymphadenectomy, removing regional lymph nodes, and reconstruction of biliary drainage using a Roux-en-Y hepaticogynostomy. For distal bile duct cancers, the standard operation is often a pancreaticoduodenectomy, Whipple procedure after Allen Whipple. Simple local resection of the tumor is generally inadequate due to high recurrence rates. The absolute aim of surgery is complete R0 resection with negative microscopic margins, while safely restoring bilioenteric continuity.
What about liver transplantation?
Liver transplantation is an option for a very select group of patients with hilar cholangiocarcinoma that is locally unresectable but has not spread beyond liver or regional nodes. Protocols like the Mayo Protocol from the Mayo Clinic involve rigorous patient selection, often preceded by neoadjuvant chemoradiation therapy and mandatory surgical staging, laparoscopy, to rule out occult metastases before proceeding with transplant. It's an aggressive approach limited to highly specialized centers.
What's the prognosis after resection?
Prognosis after potentially curative resection is related to several factors: the T stage of the tumor, the status of the surgical margins. Achieving negative margins R0 is critical. Lymph node involvement, presence of perineural or perovascular invasion, non-papillary tumor subtypes, and poor differentiation. Even after successful resection, 5-year survival rates are often only around 35%. The role of adjuvant chemotherapy or radiation therapy after resection is limited, with no clear survival benefit consistently shown, although referral for consideration might be made for patients at high risk of recurrence, for example, positive margins or nodes. For the majority with unresectable disease, palliative chemotherapy, often with a combination like gemcitabine plus cisplatin, is the standard of care, aiming to prolong survival, maintain or improve quality of life, and prevent liver failure from biliary obstruction. Relief of biliary obstruction palliatively is usually achieved endoscopically, ERCP, or percutaneously, PTC. Surgical bypass is rarely used now except perhaps for distal lesions found to be unresectable at laparotomy.
Finally, let's cover cancer of the gallbladder. Summary box 71.9 discusses incidence.
Right. Gallbladder cancer incidence varies dramatically around the world. It's relatively rare in Western countries, 1% of new cancers, but has very high rates in certain populations like native Chileans, Native Americans, and in parts of northern India, where it can account for up to 9% of biliary tract disease requiring surgery. It's generally more common in women and typically presents in the 7th or 8th decade of life. The exact cause is unclear, but there's a strong suggested association with gallstones and the chronic inflammation they cause.
What are the specific risk factors?
Beside gallstones, present in most patients, a porcelain gallbladder, wall calcification, carries a small increased risk. Chronic infection, particularly in typhoid carriers, significantly increases the risk.
Yeah.
Other factors include PSC, especially with IBD, an anomalous junction between the pancreatic and biliary ducts, and certain gallbladder polyps, figure 71.40. Again, the risk of malignant transformation increases with polyp size.
What type of cancer is it usually?
The vast majority, about 90%, are adenocarcinomas. Squamous cell carcinomas can occur, arising from areas of squamous metaplasia in the mucosa. At operation, localized cancer can be difficult to differentiate from severe chronic cholecystitis. It often appears as nodular thickening or diffuse infiltration of the gallbladder wall. How does it spread?
It spreads readily by direct extension into the adjacent liver, segments I, B, B, and V. It can also spread via peritoneal seeding, through the lymphatics draining to the perihilar nodes and along neural plexuses. Unfortunately, the majority of patients have advanced disease at the time of presentation. What are the clinical features?
Often asymptomatic early on, or symptoms are indistinguishable from benign gallbladder disease like biliary colic or cholecystitis, especially in older patients. Symptoms like jaundice, usually from invasion of the common duct, anorexia, and weight loss are typically late features, indicating advanced disease with low resectability and poor chance of achieving negative surgical margins. A palpable mass in the RUQ is also usually a late sign.
How is it investigated and staged?
Laboratory tests are often non-specific or might show mild anemia, leukocytosis, or mildly elevated transaminases consistent with obstruction. Tumor markers like CA19-9 and CEA are elevated in about 80% of cases but lack specificity. Preoperative diagnosis is often suspected on ultrasound and usually confirmed and staged with high-quality, contrast-enhanced CT of the chest, abdomen, and pelvis, or MRI-RCP. Staging aims to determine the local extent of the tumor, liver invasion, vascular involvement, and, crucially, to exclude distant metastases. Figure 71.41 shows potential spread. Summary box 71.1 lists the aims of staging. Assess local extent, detect metastases, liver, peritoneum, lymphatics, extra-abdominal. Percutaneous biopsy is generally reserved only for confirming unresectable disease before starting palliative treatment to avoid potential tumor seeding along the needle track. Laparoscopic staging is considered mandatory before attempting a formal laparotomy for resection, as it can detect small liver or peritoneal metastases that preclude curative surgery. PET scanning may also be used to look for metastatic disease.
What is the treatment and prognosis?
Sadly, the majority of patients present with advanced disease and are candidates only for non-surgical palliation. For those potentially resectable, staging laparoscopy is mandatory first. If no metastatic disease is found, the standard curative intent operation is a radical en-bloc resection. This typically involves removing the gallbladder along with a wedge of adjacent liver tissue, at least 2 centimeter margin, or anatomical resection of segments I, V, B, and V, plus resection of the extrahepatic bile duct if it's involved, or if the cystic duct margin is positive on intraoperative frozen section. A regional lymphadenectomy, removing nodes along the common bile duct, portal vein, hepatic artery, and behind the duodenum, is also a standard part of the procedure. The absolute aim is complete R0 resection with negative microscopic margins.
What about gallbladder cancer found incidentally after a routine cholecystectomy?
This happens occasionally. The need for further surgery depends on the stage of the incidentally discovered cancer. For very early stage cancer confined to the mucosa, TIS or T1A, with a negative cystic duct margin and no evidence of residual disease on imaging, observation might be sufficient. However, for cancer that invades the muscle layer or beyond, T1B or higher, a second, more radical operation, resection, is generally recommended. This involves resecting the gallbladder fossa, liver wedge, and performing the regional lymph node dissection. If the initial cholecystectomy was laparoscopic, the port sites should be examined, as disease found there indicates generalized peritoneal spread and a poor prognosis, although routine excision of port sites is not generally recommended.
Is there a role for adjuvant therapy?
Yes, adjuvant therapy, typically oral chemotherapy with capecitabine alone, or sometimes combined with gemcitabine or oxaliplatin, may offer a survival benefit after potentially curative resection, especially for node-positive or margin-positive disease.
What's the overall prognosis?
Unfortunately, gallbladder cancer remains a lethal disease with a generally grim prognosis. The overall median survival is less than 6 months. Even after potentially curative resection, the 5-year survival rate is only around 50% for localized disease, often quoted with adjuvant chemo, dropping dramatically to 2 to 5% if distant metastases are present.
How is advanced disease managed?
Palliation for advanced unresectable disease is best achieved non-operatively. Relief of obstructive jaundice, if present, can usually be managed with endoscopic ERCP or percutaneous PTC stenting after multidisciplinary discussion. Surgical bypass is rarely necessary. Pain control and nutritional support are also key components of palliative care.
Wow, that really was a deep dive. We went from the microscopic details of the crypts of Lischka and the delicate dance of bile concentration all the way through the potentially life-threatening complexities of stones, infections, congenital issues, and cancers. We certainly did. And we saw how anatomical variations, often subtle, can have enormous implications during surgery. We explored the incredible array of imaging techniques used to visualize this hidden system, from simple ultrasound right up to complex ERCPs and MRCPs aimed at nailing down a precise diagnosis.
It's truly remarkable how a seemingly simple organ and its network of ducts, often overlooked until there's pain, require such detailed knowledge and precision from medical professionals. Understanding things like the critical view of safety or the nuances of bile duct injury repair, it really drives home the sophistication involved.
Exactly. And recognizing that even common issues like gallstones can cascade into these complex scenarios underscores the importance of understanding the whole picture, the anatomy, the function, and the potential pathologies. It gives you a real appreciation for the level of detail needed for mastery in this field.
So here's something to ponder as you wrap up this deep dive. Considering the delicate balance and intricate pathways involved in this system, What does this detailed look reveal about the hidden complexity within your own body? And how does that change the way you might think about seemingly minor symptoms or the precision required in modern medical care?
It's a powerful reminder, isn't it, of how intertwined form and function are in maintaining health, and how quickly that balance can be disrupted when things go wrong in even a small area.
Thank you for joining us on the deep dive into the gallbladder and bile ducts. We hope you feel significantly more informed about this vital and surprisingly complex system.